Hi, I'm Dr. Jack West, medical oncologist and thoracic specialist at Swedish Cancer Institute in Seattle, Washington. I'm also the founder and president of GRACE, Global Resource for Advancing Cancer Education. A central question as we think about second-line treatment, the next treatment we would give after a patient progresses on a first treatment approach, is whether to test PDL1 expression on a patient's tumor if it hasn't already been done. Now, PDL1 is a protein marker that is seen on some but not all cancer cells, and some patients will have high levels of this protein on their cancer cells, some patients will have a little bit of expression, and some patients will have no expression of this protein on their cancer cells. And the issue is whether knowing this information is going to help us make better decisions about the next treatment approach to give our patients. Now, the issue is that some of our immunotherapy treatments that suppress the braking system against the immune system and can therefore lead the immune system to have a better chance of recognizing and attacking a lung cancer, some of these treatments are only approved for patients who have a certain level of expression of this protein, and some are not dependent on that. The approval is for patients regardless of whether they have any or a little or a lot of this PDL1. So at this time, as of the summer of 2017, the FDA has approved 3 different agents that are called immune checkpoint inhibitors, all given intravenously, either every 2 or every 3 weeks, and that can turn off one of the braking mechanisms and lead to better immune function against the cancer. One of those agents, and the first to be FDA approved, is called Opdivo or nivolumab, and this agent was approved without any requirement to have PDL1 expression at a certain level to give it. Patients seem to benefit well even if we don't just cherry pick patients with certain levels of expression of this marker that is associated with overall a better chance of doing well. Another agent was approved later, called Keytruda, as a second-line treatment after patients had received initial treatment, usually with chemotherapy. And this approval is only for patients who have at least a little bit of PDL1 expression or staining on a pathology test. And so it is not commercially available and approved for all patients with lung cancer, but you would need to do testing for this PDL1 to be able to get it. And a third agent called atezolizumab or Tecentriq, also approved by the FDA as of late 2016, was approved without any requirement for PDL1 testing or certain levels. And in fact, the data that they have suggests that patients, regardless of the level of expression, all seem to do better with Tecentriq than second-line chemo with Taxotere or docetaxel, a commonly used agent. And so where does this leave us? In patients who haven't had PDL1 testing of their tumor at some point earlier and they're now looking at second-line treatment, an oncologist actually has 3 potential options that are very comparable in how well they do. The different studies all looked at these 3 agents compared to the same comparator of Taxotere, and they all show a several-month survival benefit. However, 2 of those are FDA approved without requiring a PDL1 level to give them, and one, Keytruda, does require that. Because of that, if patients haven't had PDL1 testing, my personal approach is to not necessarily do testing, because you can give 2 very good agents that seem to work as well as Keytruda without having to do that testing. My own personal preference has been for Tecentriq because that is given every 3 weeks, but any of these 3 is an appropriate and very comparable choice in how well they seem to work, as well as their side effect profile. So it's really a judgment call, but I would say that there is not a clear need, any mandate, to do testing for PDL1 in patients who haven't had that done and haven't received immunotherapy as a first-line treatment.